Testicular torsion. Testicular torsion is twisting of spermatic cord leading to ischemia and possible testicular infarction. Typically affects those with less than 30 years of age, presents with intense acute onset of scrotal pain that remains the same or increases with the scrotal elevation, that is Ferenc sign. Pain is often accompanied by nausea, vomiting, and dizziness, and there may be loss of cremastic reflex on the physical examination. Doppler ultrasound shows decreased blood flow to the testes, and if there is high clinical suspicion for testicular torsion, do not wait for ultrasound and one has to proceed with surgery. Management include attempted manual detorsion, immediate surgery to salvage testis, as the testis is often unsalvageable after 6 hours of ischemia, or orchidoplexy or both testes to prevent future torsion. Patient might present with abrupt onset of scrotal pain associated with localized swelling, tenderness. In a young male, it might be due to testicular torsion, and which is caused by the twisting resulting in compression of the pemphiform plexus and reduced venous outflow. Testicular torsion is a surgical emergency because irreversible damage to testis can occur rapidly due to impaired blood flow. Diagnosis of testicular torsion is often made on the clinical finding. Shortening of the spermatic cord can cause testis to ride high in the scrotum with a long axis oriented horizontally, that is, bell clapper deformity. In addition, the cremastic reflex, that is, the upward retraction of the testis on pinching or stroking of the inner thigh, will be absent in almost all patients. If uncertain, the diagnosis can be confirmed by Doppler ultrasound showing the lack of blood flow to the affected testis. Other differential diagnosis of testicular torsion is varicocele, which is characterized by distension of pemphiform plexus within the spermatic cord. Examination findings are often described as bag of worm in the scrotum. Varicocele is a chronic disorder and it does not require urgent evaluation. Mumps parotitis can also give epididymoorchitis and present with a unilateral scrotal pain and swelling. However, mumps is uncommon in developed countries and does not require surgical intervention. Pain in the elevation of the testis suggests epididymitis rather than torsion, although it has low diagnostic utility. Epididymitis does not require surgical intervention and can be treated with antibiotics, ice, and elevation. Transillumination is an important examination to rule out hydrocele, which is a collection of fluid between the parietal and visceral tunica vaginalis. It can be testicular swelling, but usually does not cause acute severe pain. An incarcerated inguinal hernia can also present as a growing swelling with pain and vomiting, and a palpable mass can be seen in a transient bulge with a cough impulse and cough reflex positive and a bulge positive or Valsalva with uncomplicated hernias. Uncomplicated hernias do not cause acute pain, they can be managed urgently. The causes of acute scrotal pain could be testicular torsion, epididymitis, and Fournier's gangrene. Fournier's gangrene causes severe pain from anterior abdomen to scrotum and penis, and skin edema, crepitus, blisters, bulla, and urgent surgical intervention is required. In epididymitis, the urinary frequency and urgency would be increased. There is induration, swelling, and tenderness of the epididymis. Pyuria and bacteria will be present. And as we discussed, the points which are important in testicular torsion is severe pain involving entire testis, prolonged testicular swelling, high riding testis, and cremastic or absent reflex, and there might be a clapper belt deformity. Thank you.